Good morning, everybody. I'll be talking about pediatric CNVM, the etiology and treatment outcomes with intravitreal anti-VEGF in our setting. No financial interest and conflict of interest. As we know, choroidal neovascularization is a visually debilitating disease in adults and children. But the most common cause in adults are ARMD, and it's varied in children. You can see there are infectious causes, pathological myopia, hereditary choroidal degeneration, ocular trauma, neoplasias, and idiopathic. And as we know that what need for treatment is, in adults there is a tremendous burden of visual acuity being reduced, but then the children have to live with it for a longer year, and longer blind years are there, and higher disability adjusted life years. So the treatment modalities for the past were laser photocoagulation, submacular surgeries, photodynamic therapy, transpupillary thermotherapy. But recently we have been using a lot of anti-VEGFs as treatment modalities. So our aim was to share demographic detail, etiology, pattern, and pattern of presentation, long-term outcomes of pediatric CNVM following anti-VEGF therapy. Methodology, it was a retrospective study of 26 eyes of 23 pediatric patients less than 18 years, and it was a 10-year study. And the data abstraction were age, gender, laterality was taken, presenting complaints, etiology, visual acuity, and multimodal imaging. The data analysis were done by Microsoft Excel and statistics by GraphPad. The inclusion exclusion criteria, all the patients with the relevant data and all complete data were taken, incomplete data was excluded, and patient with follow-up of more than 6 months were taken into consideration. And previously treated with laser or anti-VEGF were excluded, incomplete data was excluded, any other ocular pathology they were excluded. So visual acuity, fundus examination, FFA, ICG, SD, OCT, and when necessary and relevant, OCT-A was also taken. The regimen we followed was monthly pro-rata till CNVM regression was seen. By doing SD, OCT were taken into consideration, and the monthly follow-up of patients were who are undergoing the anti-VEGF treatment were taken OCTs for to give the treatment regimen, and those cases with the additional uveitic features were given anti-inflammatory treatment too. The demographics features 26 eyes, 23 consecutive pediatric patients were taken, and in that mean follow-up was 8 to 72 months, and in females were more seen to have this CNV, and laterality was unilateral. In demographic features, you can see the mean age was 11.7 plus or minus 3.3, and the range was from 4 to 16 years. Right eye was of 54% and 46 of left eye. The main symptoms which were there were the diminution of vision. Squint was of only 12%. The demographic features of the cause etiology in our study was inflammatory or uveitic, which accounts to 62%. The second was idiopathic of 19%, followed by choroidal dystrophies 12 and traumatic in 8%. Out of the 62% inflammatory, the toxoplasma was the highest, followed by multifocal choroiditis, VKH, presumed TB, and posterior uveitis with the unspecific etiology. According to the location and types, the location we had the subfoveal the highest, followed by the peripapillary, and then the extrafoveal location. And the type 1 was around 17%, and type 2 was of 83% in our study. Functional and anatomical results, you could see that at presentation the lobmar visual acuity was 0.8, and which in the final visit was 0.4. So there was a gain of 0.4, that's 20 letters, and it was statistically significant. The same as central macular thickness was 405, and in the final visit after the injections were 249 with the same reduction of 156 mean, and it was statistically significant, and there was nil complication of any of these anti-VEGFs. There was one CNV secondary to choroideremia had a recurrence after 6 months, for which we had to give another injection and regressed. The mean injection per eye in our study was 2 injections. As you can see, the regression patterns in VKH of and OCTA showing the regression pattern as well. This is a case of penetrating trauma, which have she's seen regression after injections. This is a picture, OCT picture of best disease with regression photos and as the OCTA photos. When literature review, and we have found that there are many studies done, but then all were single-centric, but they didn't have a lot of samples, and out of them, multicentric were major, and all of these had just 35 to 45 cases, but they were all multicentric. Our study was single-centric. In discussion, I would like to say the pediatric CN waves as associated with underlying ocular comorbidities, which comprises the retinochoroidal integrity, allows the development of new vessels. And spontaneous regression can occur due to preserved RP Brooks integrity, that is 20% of spontaneous regression was seen in our series. And anti-VEGF injection were the mainstay of treatment in pediatric CNVM and respond well to therapy with mean number of 2 injection in our. With the faster regression or lower recurrence risk.
Can you sum up
CNV,
faster? Time is up.
Adopting a PRN approach may be the best thing. And the limitation of this, it was a retrospective study, and the rarity of the disease is the major concern over here. So this was a single-centric study with the 28.1 mean. And anti-VEGF is safe in pediatric CNV and favorable prognosis with fewer anti-VEGFs were required and lower tendency of recurrence. Thank you.
Just one. Yeah, thank you. Just one question from the panel, please. Please go ahead, sir. Anything? I think well presented. Due to lack of time, we'll skip the question.